Okay, this is going to be a small presentation on Gaucher disease. Gaucher's disease is one of the most common of the lysosomal storage diseases, and there are over 40 different lysosomal storage diseases. They're under the umbrella of inborn errors in metabolism, and as I said, Gaucher's is the most common. Here is a diagram. Here's Gaucher's disease, which is the most common. The least common is Tay-Sachs. And they're all caused by different enzymes that are important in the lysosomes to break down various either proteins, nucleic acids, carbohydrates, and whatnot. And when they're not being broken down correctly, they get into the lysosomes, but they can't get out. So the lysosomes get larger and larger and cause a lot of trouble. And this is actually, I think, a really good kind of study guide for you as far as lysosomal storage diseases. So in Gaucher's disease, glucocerebroside cannot be broken down to ceramide through this enzyme, and this is glucocerebrosidase. So the first step of ganglioside in gangliobrain to GM3 is caused by an abnormality hexosaminidase A, and this causes Tay-Sachs. Number 2 is going from ceramide trihexide to glucocerebroside, and this is abnormality in alpha-galactosidase, which we discussed back in the stroke case. And then number 3 we just talked about. In number 4, aerosulfatase A, the sulfatides go to galactocerebroside, and when that's not working right, that causes something called metachromatic leukodystrophy. And glucocerebroside to ceramide, again, another way to get to ceramide is Krabbe's disease, which is usually presents during infancy with increased muscle tone, spasticity, and it's a progressive disease that usually results in death, very similar to Niemann-Pick, which is caused by sphingomyelinase going to ceramide from sphingomyelin. So again, this is a really good kind of a review of all lysosomal storage diseases and how the enzymes work, and this is the one for Gaucher's. So the genetics of Gaucher's disease is, or some people call it Gaucher's disease, is inherited in autosomal recessive fashion. The most common type 1 is non-neuropathic. It's most common in the Ashkenazi Jewish population. 1 in 500 individuals of Ashkenazi Jewish descent have Gaucher's. The incidence in the general population is about 1 in 500,000. It's caused by mutation of the GBA gene, which again codes for that enzyme, and the most common mutation is known as N370S. So here we have the pathway again, and glycosaminide is broken down into ceramide plus glucose, and glucose is something that we need in all cells, and so the glucocerebrosidase is the enzyme that's not working right. Now the problem is the accumulation causes a lot of problems, and it causes ischemic events right in the bone that causes loss of bone tissue, especially aplastic ischemia. It also affects the bone marrow as far as creating blood products. It affects the liver. This is actually, the liver gets enlarged. It's not as much the accumulation of the lysosomal byproducts as it is believed to be an inflammatory reaction, but the hepatocytes are spared. They affect the osteoclasts. It results in respiratory issues because of alveolar macrophages and problems in, again, it's probably more inflammatory than actually the accumulation of the lysosomal byproducts that causes the splenomegaly, but the spleen can get incredibly large. And so here's just a little diagram. So reduced hemoglobin results in anemia and fatigue. Reduced platelets results in bleeding and bruising. Reduced lung function can result in shortness of breath. Liver and spleen enlargement can result in abdominal pain and discomfort, and reduced bone density can increase the risk of fractures as well as causing bone pain. And so here is a picture of a little boy with this very enlarged abdomen, splenomegaly, hepatomegaly, causing abdominal pain, bone disease, bone pain and crisis, and growth retardation. They have decreased bone density. Thrombocytopenia can result in bruising and bleeding, and then, of course, anemia. Now, pathological, when you're looking at the pathologist, there are specific findings. In a peripheral smear, you see these things called inclusion bodies, and this is a sign on the peripheral smear consistent with Gaucher's disease. And on a bone marrow, the bone marrow cells show this kind of newspaper, crinkled, they call it crinkled newspaper in the cytoplasm. These are the cytoplasm filled with all the lysosomes, and these are, so this is called a Kupffer cell. These are very specific for the pathologic diagnosis of Gaucher's disease. Symptomatic treatment, and again, this was first described in 1850 by Dr. Gaucher, and they didn't have a lot of other therapies, so symptomatic treatment of Gaucher's, hematologic, iron and vitamin, blood transfusions if you're super anemic, and if the spleen is too large and causing too much trouble, you take it out. Skeletal, pain management, joint prostheses, calcium supplementation, fracture management, core decompression. But again, those are only going to treat certain symptoms. They're not going to treat the actual problem. We've had actually enzyme therapy for the treatment of Gaucher's disease for approximately 30 years, 25 to 30 years. And it's administered through IV every 2 weeks. And so we do have a fair amount of time in this therapy, and we've shown that there's an improvement in the symptoms after the first few months. And this improvement, the therapeutic results include a hematologic, a 2.5 gram per deciliter increase in hemoglobin, and a 50% increase platelet of those patients that still have a spleen. Unfortunately, because of this therapy, we haven't had to perform as many splenectomies as we used to, because there are complications in splenectomies. As far as visceral, hepatomegaly, and splenomegaly, a 20% decrease in the size of the liver after 9 months of therapy, and a 45% decrease in the size of the spleen after 9 months of therapy. So we can prevent having to remove the spleen by putting these patients on IV therapy. And again, we're treating the actual core symptom and not every core problem, and not necessarily the symptoms. So as I said, IV enzyme therapy is given every 2 weeks for the rest of the individual's life. And there are a few different forms of IV therapy, different companies that make it. It's given for the first year in an infusion center, and this is usually to look for any signs of inflammatory, allergic reactions. But once that happens, it can be moved to home infusion. The nurse comes in, pops in an IV, and gives this infusion over about 2 hours. One of the bad things is this infusion costs about $10,000 per infusion for the rest of the person's life. Another option for treating lysosomal storage diseases, and specifically Gaucher's, because that's the most common and the most research has been done, is a substrate reducer. If you don't, the problem is if you can't break something down, don't make as much. So here is, if we have a lot of substrate and only this much is coming out, this is accumulating in the cell. But if we don't make as much, then we don't have as much accumulating in the cell, and then we're still breaking down a little bit. So this inhibits the synthesis of the glucocerebrosidase. So let's inhibit the first step of this product that we can't break down. Hopefully the residual enzyme will be able to, take care of some of this. These are oral medications, and there are actually 2 medications that are currently in clinical use. And in Gaucher's disease, it's actually now considered to be the first line. So, we get to these patients before they have such severe issues that they have to have their spleens out or their livers. Well, you can't really take their liver out. Well, you could if you did a transplant. But anyway, the results, though, are actually very impressive and very similar to that of IV therapy. And for this reason, it's now considered a first-line therapy. Unfortunately, you know, the cost is the same. Drug companies like to make money. The patients, though, not everyone, this is not amenable to everyone. They need to have testing from the P450 system, specifically the CYP2D6 gene. If they're an ultra-rapid metabolizer of this chemical, not enough will get into the bloodstream for an adequate response. So we need to make sure they're not ultra-rapid metabolizers, CYP2D6. Only about 2.5% of the population in general are ultra-rapid metabolizers for this particular gene. So most people are, but it needs to be tested before we start them on this also expensive therapy. Another method that's going to be looked at, that we don't have any FDA-approved drugs today, but another method to help in this situation is molecular chaperones. And chaperones are substances that stabilize the 3D structure of the enzyme and allow it to function better. And these are also oral medications. And there are actually a number of medications in the product line for both Gaucher's and Fabry's. Again, this probably won't show up on step 1, but it's something to understand as you move forward. Gaucher disease and Parkinson's. So family members of patients with Gaucher disease have been noted for quite a while to have an increased risk of developing Parkinson's disease. Approximately 10% of patients with Parkinson's disease are a carrier for one of the non-functional GBA genes. Again, you have to have both copies not working to develop Gaucher's disease, but if one isn't working, you're at increased risk. So if you're a carrier for Gaucher's, we used to think if you're a carrier of something, you're fine. But if you're a carrier for the GBA gene mutation that causes Gaucher's, you're at an increased risk to develop Parkinson's disease. The GBA mutations in carriers lead to a reduction in the amount of intracellular glucocerebrosidase. Although not sufficient to cause Gaucher itself, it's thought to be associated with the problems in Parkinson's. Even a minor reduction in the glucocerebrosidase activity can promote deposition and chemical injury in specific neurons that increase the risk to Parkinson's disease. So in conclusion, Gaucher's disease is the most common of the lysosomal storage disorders. It presents during adulthood in most cases with a wide variety of symptoms, including anemia and hepatomegaly, so it can be in a differential of quite a few disorders. Gaucher's is a progressive disease, again affecting many organs, including bone, blood, liver, and spleen. And targeted therapies have been shown to increase symptoms. Of course, unfortunately, this shows the answer, but a 50-year-old female has recently been diagnosed with a movement disorder, Parkinson's disease. The family history is positive for her father, who was diagnosed with Parkinson's at 60. She has a 55-year-old brother with Gaucher's disease. He has no symptoms of a movement disorder. What gene is likely related to a Parkinson's? And this would be this GBA gene. So she's 50, she has a Parkinson's, and her father also had Parkinson's, and her brother has Gaucher's. So if her brother has Gaucher's, her father was obligate carrier, and if you remember from our Heidi Weinberg, she's a 2/3 chance of being a carrier if she does not have Gaucher's, and by 50 we would know if she had Gaucher's, and so that is probably the result. So that concludes this module on Gaucher's disease.